Hi, my name is Amy Patton, and this is a brief sample module of teaching patient-centered communication when having quality of life discussions. This presentation is being used to represent a larger 4-hour seminar designed to be given to medical students in person when they are in their pre-clerkship. Patient-centered communication. Patient-centered communication requires the provider or clinician to elicit a patient perspective. Sometimes patients are hesitant to talk about their values or feelings. Sometimes patients and their families have never said these things out loud before. Patient-centered communication gets the patient talking about what their perspective is on their healthcare and its outcomes. Understanding the patient. We can hear what someone is saying, but we only start to understand what is being said when we can appreciate that person's unique perspective within the context of their psychosocial and/or cultural identification and values. Again, it is not enough to simply hear or understand a patient's perspective and values, but for that understanding to impact the treatment or interventions as related to those values. At this point, I would normally provide an example or two, but for the sake of the time constraints of this project, we are trucking onward. Okay, quality of life. Who determines quality of life? Well, the person to whom the life belongs, of course. Maybe for this person, walking with their spouse around the yard is what quality of life means. But what then happens when they're no longer able to walk around the yard? Maybe quality of life changes to being able to sit on the porch and holding hands with their spouse. But let's say now that the spouse has passed away and they can't sit on the porch anymore, they still have quality of life by letting their grandkids come and sit in their lap and watch cartoons with them from the bed. However, what happens if this person's no longer able to recognize their grandkids? What if they can't get out of bed anymore? What if they can't talk anymore? How is that determination of quality of life defined, and when does life no longer have quality? The only person who can decide that is the person living that life. Quality of life is an individual's perception of their life in context of the culture and value systems in which they live. This also has to be taken in consideration to life goals, life expectations, life standards, and life concerns. This is frequently a difficult topic to broach, but in my opinion and my experience, once you can get a patient or family talking, it is easy to define and navigate what quality means to them. You just have to be brave enough to start the conversation. Okay, hang in there. Do not be scared. You're doing great. There are lots of resources out there to help you. One of the ones that we're going to talk about is through the World Health Organization. They actually have a quality of life brief questionnaire, which is a standardized set of questions that then get scaled answers, determining ultimately what the patient's perceived quality of life is. I'm not going to walk you through all 26 questions. Instead, I'm just going to highlight a few of them to help get the juices flowing for how we're going to facilitate a conversation. So you could ask, to what extent do you find joy or meaning in your life? Are you able to accept your bodily appearance? How satisfied are you with your ability to perform your daily living activities? How often do you have negative feelings such as mood, despair, anxiety, or depression? How satisfied are you with your health? And how would you rate your overall quality of life? Now, here's the thing, and I think this is very important. Just because someone has a perceived low quality of life does not mean that we are done. We don't shake our hands and say there's nothing else that we can do, right? There's always another service that can be offered. There is always another service, whether that is a medication, whether that is a therapeutic intervention, whether that is a counseling service, whether that is a palliative or a hospice consult, whether that is offering comfort or grief counseling. There is always something else that we can be doing. So number one, I want you to have that in your head. Number two, the way that you're going to have this conversation is we're going to talk about where the patient's realistic expectations and prognosis are in relation to their rehab potential, right? So if we're quality now or we're scared about a poor quality of life, how does that relate to what is a reasonable rehab expectation, right? If we have poor rehab expectations, we have poor medical prognosis, and that is all leaning towards indicators that you will have a poor quality of life, that's going to be a very different conversation than getting you through a current poor quality of life and figuring out how to enhance that for an ultimately good rehab prognosis. Either way, you have to know your patients and what matters to them. Whew. All right, y'all, we have covered a lot of ground. I want to take a few minutes for some personal reflection. I want you to sit quietly with your thoughts and just jot down a few ideas. Where are you at? Does this seem hard? Have you learned anything new? Is there anything you want to learn more about? After a few minutes, I'm going to put up some discussion questions, and then I want you to take a few minutes and answer them yourselves before you move into small groups with those around you and discuss your answers. All right, y'all, discussion questions are up. Remember, I want you to please answer them yourself and then move into small groups of 2 to 4 with those sitting around you and discuss your responses. I'll be walking around the room if you have any questions. All right, y'all, we're back. Now that we've looked a little deeper into what your values are and where those values come from, I want to dive a little bit further into bias. A famous Maya Angelou quote is, "Do the best you can until you know better. And when you know better, be better." An unconscious bias is just that. It's unconscious. It's unintentional. It is social stereotypes about certain groups of people that individuals form outside their conscious awareness. All right, do not laugh at me. I got on the TikToks ages ago. I really like the TikToks, and I came across this lady, and I thought she did a great job explaining bias, and now I'm forcing you to watch a TikTok video. Enjoy.
I remember being in nursing school and the class where we learned about different cultural and religious, cultural and religious diversity and how that affects healthcare decisions. And I remember learning specifically that there were certain people who defined as Christians, their specific religions as Christianity, did not allow them to accept blood products. Even in the event of emergency, they would not accept any blood products, meaning even RH factor, even if it meant something really bad could happen. And I remember speaking up and going, "Now that don't make no sense." You know me, I'm young and honey, I got a mouth. And I said, "Now that don't make no sense. We know what's best because we know if your hemoglobin is 3 and you're bleeding out, you could die. And that don't make no sense." And I had a wonderful instructor who said, "Don't make any sense. By whose standards?" I said, "Well, that's just common sense." She said, "Is that common sense or is that your value?" And my life changed in that moment. And I realized a good part of my life, I had been placing my values as the standard. Like I knew everything. Like I just knew what was the best thing. And let me tell you something. When you have a patient and they're bleeding out and you know physiologically what's happening, and they're telling you, "I'm not accepting any blood products that'll save my life." And you go, okay, I support you. I'm your advocate. I am your advocate, meaning I fight for your right to choose what you believe is best for you. And my beliefs and my values don't come into play here because there's no room for bias when I'm advocating for another human.
Woo-wee, that's a good word. All right, y'all. I want you to take a few minutes, get back in those discussion groups, look at the different types of biases that are up on the board right now, talk through them. Who do you identify with? Who do you not know anything about? What are assumptions that you have? What are things that you assume going into conversations? What do you expect to be certain ways with certain types of people? Discuss. We will come back shortly. All right, we're going to wrap this up with another group share opportunity. Normally, I would have other activities during this seminar that are being cut, like role play, group discussions, things like that. I think there's a lot of really important things that happen out of group discussion, but for the sake of this project, those items are missing. Thank you so much for your time. I hope you enjoyed it. Thank you very much.